your kind introduction, and also thank you for coming out on this snowy Sunday morning to talk about supplements for pain, and are they really mythical magic or real medicine? I was thinking about retitling this presentation Beyond Opioids and NSAIDS. Back in the day, pharmacists really used these medications, or these supplements and vitamins, as real medications. And ancient history shows that these agents did have anti-inflammatory and analgesic properties. And I remember back at Ferris, where I did my undergraduate pharmacy curriculum, that in botany, that these agents did truly have anti-inflammatory and analgesic properties, such as the extract of the white willow bark. And there is evidence that the white willow bark, where we use the extract for salicylin, does have anti-inflammatory properties and is still used for non-specific low back pain. And devil's claw, in fact, is recommended as having very strong evidence for arthritic pain by a Cochrane 2007 review, and also has very, very strong evidence for use in low back pain as well. Basically, my botany now is limited to trying to impress the tree surgeons to get a better price on their estimates. So. Now, the objectives here are there. I won't read them for you. You can refer to them at your leisure if you haven't already. So, why do we continue to discuss pain management and year after year, and why is the state now having it as an essential piece of our practice requirements? Pain is prevalent and disabling. In fact, low back pain and chronic neck pain are the two major causes of disability in our industrialized nations. Pain is costly. I know in my practice, pain is the major reason that our students and our adolescents continue to miss school and also work. When our patients come to the Children's Pain Management Clinic, we find that on the average, they have missed 18 days of school by the time they come and are seen as patients. And we find that a child that has missed 10 days of school is at risk for not graduating on time when they're in high school. It affects their quality of life. Patients with chronic pain are 50% more likely to have a divorce. Their pain is the primary reason for seeking care in the primary care setting or in the ED. Patients who have chronic pain have very high medication and supplement use, and that's of great interest to us as pharmacy practitioners. The consequences of chronic pain. We find that patients with chronic pain have a very high rate of emergency department and physician visits. There's, again, lost productivity and a high disability rate with chronic pain patients. There's a very, very high rate of drug diversion and abuse and overdose. If you ever read the Middleton studies, those came from the University of Michigan group, where it shows that 1 out of 4 students at the high school age have admitted to using prescription medications. Not street drugs, but prescription medications, oxycodone, hydrocodone-based medications. And they state that they have used these from a parent's medication cabinet, grandma's purse, or they've obtained this from a prescription that was maybe too liberally prescribed for them. Let's say they had a wisdom tooth removed and the prescriber, in a well-meaning attempt to treat their pain, maybe prescribed 90 tablets instead of maybe 30 or 15 to get them over that acute pain, and they just sort of stockpiled it and started abusing it. Drug-related problems are very common in the chronic pain population, such as dose too high, dose too low, inappropriate indication, adverse drug effects, drug interactions, drug-disease interactions. These are very common among chronic pain patients. Depression, half our patients come to the chronic pain clinic with significant depression. Anxiety is very common, and a third of them come to chronic pain clinics with significant sleep disorders. Relationship problems, I alluded to that already, with a higher divorce rate. And we find that younger patients withdraw. They find that their friends change. They become an object of bullying because of their chronic pain issues. Also, litigation. There's a lot of problems with litigation. Patients become dissatisfied, disenchanted with their pain medications, their physician's lack of ability to address their pain appropriately, and pharmacists as well are being named in these litigations as well. This is an electronic microscopy image of a neuron. The CNS contains trillions and trillions of these neurons, and I'm just showing this to you now is that what is exciting about some of these supplements and their ability to prevent further degradation of inflammation and also the oxidation that is caused by diabetic neuropathy and hyperglycemic changes in these neurons and the dendritic ends of the neurons that has been induced over time by sustained high blood glucose, and also in complex regional pain syndrome, which is a chronic prevalent pain condition after an injury. Some of the supplements that we'll talk about later on, such as the omega-3 fatty acids and vitamin C, have been implicated in slowing down the degradation. Pain is an alarm. Pain is a symptom. And many of our agents that we have been using over time, such as the opioids, and even the gabapentinoids, gabapentin, pregabalin, they're Band-Aid types of approaches. They relieve the symptom. They do not address the cause of the pain. And what's exciting about some of the supplements and vitamins that we are using in the multimodal types of management of these issues is that they are actually slowing down the nerve degradation and the chronic degenerative changes that are actually causing the chronic pain syndromes. What is very concerning is that as chronic pain continues over time, is that we have continuous changes. Let's see if I can get a pointer going here. Maybe not. In the cerebral cortex. This is a CT scan that shows changes over time with chronic pain, almost as in terms of an Alzheimer's type of or dementia changes. Chronic pain does thin the brain, as we say in the pain management arena. This shows chronic cortical thinning over time of the cortex. So it is very important to address chronic pain very aggressively. This has been shown in a study where it's a very small group, so therefore the results are limited, but on an MRI where we had some chronic low back pain patients that were given spinal injections or surgery to control the pain that was caused by disc compression. They were compared over time, their MRI changes with functional healthy controls, and they were evaluating on MRI their cortical thickness. And MRI scans 6 months pre and post treatment showed that a cognitive task performed during the MRI, the functional changes on MRI, their cortical brain function improved during and after. Well, their cortical function improved as measured on MRI after treatment. And this shows that even the ability to learn during early childhood, adolescence, and even during adulthood, their ability to work and perform is slowed by chronic pain. We do have limits to our conventional therapy, and we do know this as pharmacists. NSAIDS. NSAIDs are one of the most commonly prescribed medications for pain management. It's estimated that at any time, 10% of the population is taking an NSAID, either prescription or OTC. 14% of our elderly take an NSAID on a chronic basis, and 8% will bleed at one time or another. So that is a true limitation. These drugs have significant adverse effects. Opioids. Opioids are limited by their ability to manage pain only very short term, and for neuropathic pain, opioids are not effective. They are limited by tolerance, they have a heavy abuse potential, and over time we're finding that in a young child and an adolescent that opioids can cause permanent changes in the developing brain. The Pentanoids, gabapentin, pregabalin, they have many adverse effects, even though they are generally very effective for neuropathic pain. These drugs are often not well tolerated because of their effects on peripheral edema and cognitive function. Antidepressants, these agents are often, like duloxetine, very well tolerated in some patients, though in younger patients we're finding that many times they're not well tolerated because of nausea. Skeletal muscle relaxants are not well tolerated, and there is an abuse potential with cyclobenzaprine. We all know the soma syndrome that is often abused, and over time there is a tolerance. Many states in their Medicaid program are putting a 21-day limit on the acute use of skeletal muscle relaxants, and Michigan is looking to do the same. Skeletal muscle relaxants, too, many times their use is limited. They have a central activity where it's sedating, and there's only 2 agents, tenazepam and baclofen, that have a true physiological skeletal muscle effect on the end plate. So we're very limited with skeletal muscle relaxants, and many patients resort to the use of benzodiazepines for skeletal muscle relaxation. And we all know that benzodiazepines have a limited potential with respect to long-term use because of dependence and sedation. Procedural interventions, we all see what happens with procedural interventions if not carefully controlled, they're manufactured, and also they are high risk and costly. So, what are our other options? Physical therapy, aquatic therapy, massage, acupuncture, cognitive behavioral therapy, biofeedback, and hypnotism. What else can we do? Well, in the terms of multimodal analgesia, where we're using a variety of analgesics to maximize pain control, minimize adverse effects, we're looking for additive and synergistic effects. So we've been using local anesthetics, alpha-2 adrenergics, which is clonidine, NSAIDS, acetaminophen, opioids, gabapentin, preoperative opioids, the Pentanoids, others. And the goal is to decrease our reliance on opioids, decreasing adverse effects and length of stay. And we want to, our bottom line is to improve the patient's comfort and to improve their satisfaction. So, many times we've looked to supplements and vitamins or nutraceuticals. What's a nutraceutical? Well, back in the 90s, there was a physician who just basically took a nutritional product and just did a contraction with pharmaceutical, called it a nutraceutical. We really do not recognize that, but there have been some historical evidence, starting with magnesium in the anesthesia literature, that showed in conjunction with other analgesics, magnesium has had profound analgesic effects. And it started with anecdotal evidence, and there were some few randomized controlled trials. Now, over time, we're accumulating evidence that with fish oil, vitamin D, vitamin B complex, vitamin C, ginger extract, magnesium, that there are some vitamins and minerals and supplements that have been associated with pain relief. Now, we need pharmacist intervention. Why? Older adults, especially, have been found if they are taking greater than one prescription in OTC, that if they're, half of them are using more than one supplement. Have you found this to be true in your practice? Do you find many older adults use more than one supplement? And this one researcher that reported back in 2008 in JAMA found that the majority of them did not disclose the supplement use to their pharmacists and physicians. They felt this was private, they didn't have to disclose it. It wasn't a medication for various reasons. They just felt it was their business, no one else's. And with this self-medication, this high use of analgesic supplements and herbals, which included Chinese herbals, that there was this very high risk of drug interactions, and many of these patients ended up as inpatients in hospital because of these drug interactions. In my own practice, in addition to children, I also interfere with drug therapy with the chronic neck pain patients. And we did a study with a physical therapist who is very eager in her own practice to screen for drug-related problems, and she's looking for an algorithm that she would like me to design so she could take over our role as pharmacists. So I tried to do a collaborative type of practice with her. And we looked at patients, I presented last year on this, but this is sort of a spin-off of this, with mild to moderate severe neck pain. And as I said before, neck pain is the second leading cause of disability in this country and many other industrialized countries after back pain. We looked at 63 patients, mean age 57, which is extremely young, let me tell you, very young. And, 59, 57 were female. And they were enrolled in a large exercise study. These patients were highly motivated, pretty healthy overall, because they wanted to use exercise as a means to also control their pain. They wanted to eventually get off of their medication. And we did a medication questionnaire, and we looked at baseline pain and disability assessments. And surprisingly, we found that in addition to all their chronic medications, 89% of these patients were using medications that they used on their own. They self-medicated, and 80% of them used chondroitin, glucosamine, vitamin D for their neck pain, and 15% were using these herbals that had no data in the literature for use in neck pain. And this included probiotics. Quite a few felt that probiotics had some data or efficacy for pain. And Chinese herbals. I don't know what's in a Chinese herbal, and I looked at the content of different patients' medications, and it varied. Ginkgo was concerning. There was a case report in the literature, in the tox literature, where a 55-year-old gentleman was taking ginkgo for pain, and he was also receiving Depakote for a seizure disorder, and the ginkgo interfered with, it induced the same CYP enzymes as the valproic acid, the Depakote, and he was swimming in the YMCA pool alone one day, and he had breakthrough seizures because his valproic acid, his Depakote level dropped, and he seized and died in the pool, drowned. He was swimming alone early in the morning. So this is profound evidence that we need to be involved and monitor these vulnerable patients. So what other issue too, though, that scared me about these patients is that 44% had multiple providers, some had 3, and some of these patients had chiropractors prescribing these herbals for them. Some had surgeons, nurse practitioners, alternative medication therapists, so we need to be aware. And I reviewed all their drug interaction potentials. 54% had drug interactions that were specific to these supplements with their prescription meds. So something to be aware of. So we concluded that there was a high rate of use overall of supplements and herbals in the chronic neck pain population, and self-medication and multiple providers really predisposes to drug interactions in these patients with neck pain. And we need some type of medication screening specific for this population, and education for patients and all providers is needed, and we need to focus really on supplement use. And there are some persistent questions and myths concerning supplement and vitamin use. And there is a persistent myth that supplements can only help and never hurt. I'm asked every day by parents at Children's Hospital of Michigan, and we do have very strict policies concerning the supplement use, within the Detroit Medical Center and at Children's Hospital as well. When the patients are admitted to hospital, the supplements that they can take from home, where they're not allowed to use them, we do not routinely allow supplement use in our hospital, and we do allow coenzyme Q10 because the genetics group does use it. We do allow vitamin C, vitamin D. We do check our sources. But many patients will say, we only want natural products in the clinic. We only want natural types of vitamins or supplements because it won't hurt our child. Natural is best. And then finally I'll say, well, arsenic is natural. Strychnine is natural. Lead is natural, and lead can hurt. Mercury is natural. We don't take in mercury. We don't want that. They're like, oh, okay, I see your point. So it's education. And where do these herbals and supplements come from? We need to be very careful about our source, because we need to remember that any manufacturer can place an herbal or a vitamin or a supplement on the market without going through the FDA. They don't go through the drug approval process. So they are controlled, but they're a different type of process. We need to make sure that we are having our patients use U.S.P verified instead of just any type of unpure or impure source. U.S.P verified just go through a rigorous U.S.P pharmacopoeia assay type of good manufacturer process. Manufacturing labeling, you'll see the U.S.P verified on the label. And we need to do a careful medication, allergy, and disease history. Many of these agents do have interaction potential with diseases and drugs. Too high doses, for example, of omega-3 can have an effect on platelets, can affect the INR. Devil's claw has antiplatelet effects. Over 2.7 grams of omega-3 fatty acids can interact with someone's warfarin. So we do need reliable also too data on toxicity and drug interactions, and that's also difficult to obtain. Sometimes you have to go to 2 or 3 different sources. We don't always know the metabolic roots of these agents, and that can be difficult to obtain as well. We need to make sure we are looking at the proper monographs or the databases, and then we need to communicate the use of these agents to all providers. And that's maybe difficult, but it's getting a little easier with the use of electronic medical records. And we need to monitor outcomes and report adverse events. There is an adverse event for the use of supplements for the FDA. There is a reporting mechanism for the use of supplements and vitamins on the FDA website. So I encourage you to look at that. And we have to remember too, chronic pain predisposes our patients to quackery, the back belt, the pain relief. Get one for your office, plane, and car. So this was on, as seen on TV. This was on the website for a chiropractor. And we all know too, all our patients too with the low back pain, they want a back brace. But if you use a back brace, it's not recommended by the American Academy of Orthopedic Surgeons, because if you use back support, your muscles in your core deteriorates, and you see so many children or adolescents coming into clinic even with back support, and the parents put it on in a well-meaning attempt to help their child, but back supports, are no longer recommended. I hate to tell, Dr. Mr. Back Belt, whoever put this together. So I watch a lot of late TV on Channel 20, so I see a lot of the quack commercials. I know. There you go. So evidence for pain reduction. There's strong evidence for vitamin C, omega-3 fatty acids, vitamin D, magnesium, salt, and coenzyme Q10. So no quackery there. Although some of the studies always don't have external validity, and they have quite a few limitations, though these are the strongest the agents with the strongest evidence for pain reduction. Now, vitamin C, it is a reactive oxygen species scavenger, and it does promote healing, and you'll see it added to a lot of cosmetics. I get really excited if I see a cream with vitamin C. I have to control myself. $65 for a jar, but it is very exciting, and it does help. I do see antioxidant neuroprotective effects. And also it does have anti-nociceptive effects. We could drink orange juice, though our blood glucose would increase, and the tablets are a very inexpensive, safe way to get vitamin C. I do remember back in the day in the family practice clinics at UHC, all the patients would come in and drink before their blood glucose, fasting blood glucose, like a pint of orange juice, and then they would wonder why their, blood glucose was 400. But we put those stickers on their diuretic bottles, drink orange juice or eat a banana, and they would be afraid, they weren't doing the right thing, so they would want to increase their potassium intake. So they'd say, I got my vitamin C today. I'd say, yeah, well, they also got increased glycemic load there. So, and it has been proven that patients post-op have endogenous ascorbic acid deficits. So, it has been shown if we replenish their vitamin C post-op, we are doing them a favor, and it also has pain-reducing effects. And somehow it modulates the nerves. We just don't know how, but somehow it modulates the nerves and it decreases pain. This has been shown since 2003, and post-op pain is so common. 80% of our patients do have post-op pain, besides, in spite of our best efforts with PCA, NSAIDS, everything we do, all our pain services. So there you go. The evidence I sort of grouped in a table for you that's been shown in adults, status post-laparoscopic cholecystectomy, elderly women after they fractured their wrist, adults after foot and ankle surgery. It prevents complex regional pain syndrome. If you give 1 gram of vitamin C post-op the day of surgery and then continue it for 45 days. And it's fairly benign as long as you aren't predisposed to renal stones. So. Now, neuropathic pain, post-herpetic neuropathy. It is the bane of the chronic pain service existence. To have someone with post-herpetic neuropathy, post-herpes zoster, significant pain, patients come in, they almost have a tent over them, or they're coming in with no shirt in the middle of winter because they cannot stand to have anything touch their trunk area because the pain is just so exquisite. So, if you replenish their vitamin C levels, it appears to help. Vitamin C is available as an infusion or as an injection. It might be on back order now, you never know. However, you can give a 1.5 gram IV infusion during an acute attack of a herpes zoster, and it appears to help. And it's been shown in studies, large and small, recent ones, that it gives significant relief even in those patients failing nerve block and traditional analgesics. So this is rather exciting. And these patients too, the neuropathy patients, tend to have significantly decreased vitamin C levels. Also, neuropathic pain. We measure neuropathic pain successful relief if we can get you down 3 points on the scale. So this is a patient with chronic post-herpetic pain, and this has been shown to have this is the best study yet, in Clinical Journal of Pain, very high impact journal. Baseline pain after 7 days, significant 3-point decrease. So there you go. This is a vitamin C infusion. Adverse effects are very small or mild unless you are prone to renal stones. Rarely dizziness, fainting. Patients sometimes complain of flushing. If you have a patient with flank pain, that could be concerning though. You might want to check for renal stones. The vitamin C causes a renal hyperoxalia, and renal stones are often composed of calcium oxalate. So that's how the pathogenesis of renal stones due to vitamin C. So there was a large study early on in 1999 showed no association with vitamin C and renal stones, but those patients were told not to take vitamin C if they had a history of renal stones. So that was the limitation right there. Later on, though, it showed that patients had a twofold increase of renal stones with ascorbic acid use. So that might be, this was with males. We don't know with females, so, but it's better to be cautious. Drug interactions, I've listed them there. They're manageable. You just have to watch. It can increase iron absorption and aluminum absorption if you use it with antacids, aluminum antacids. Now, chronic regional pain syndrome. Has anyone ever seen a complex regional pain syndrome? Yes, it's pretty significant. If you could see in the bottom corner there, some patients have actually on the affected limb where you have, it's sort of an overfiring of the nerves in the affected, in a limb after like surgery or an injury. We've had hockey players, competitive dancers, volleyball players came down too hard on one foot. The injury heals, and it's after the injury heals, the nerves continue to fire in the absence of the injury or the trauma. So the skin becomes very shiny and taut. There's sometimes edema. The hair continues to grow, and the whole affected limb or arm or foot becomes really painful to the touch. Sometimes it's hot, sometimes it's cold, the nails grow longer, and it's very difficult. Sometimes the person comes in without a shoe in the middle of winter, they can't put a sock on, and we usually use a gabapentinoid for this, but we found that vitamin C can often work. And sometimes the complex regional pain syndrome can affect the whole body as well. It can go like central. So vitamin C has also been expanded for diabetic neuropathy and sometimes too chronic pancreatitis. What about fish for healing the pain? Everyone wants to know about fish. Do you get a lot of questions about fish oil? Now, Americans spend over $15 billion a year on fish oil. Can you believe it? Now, foods that heal, omega-3 fats, they can reduce inflammation and chronic inflammation of various types. Crohn's disease flare-ups. There's evidence for Crohn's disease flare-ups. Sickle cell crises and pain. It's been proven for coronary heart disease, increasing HDL, decreasing triglycerides, reduce the risk of certain cancers, may improve brain function. In fact, for premature infants, there's evidence that omega-3 fatty acids added early on to the formulas, or even to like in increasing the intake in pregnant women, though you need to be careful not to expose them to heavy metals, may improve the health of the unborn child, and also improving ADHD. Now, omega-3s, how much fish do you have to eat? Well, the most potent fish would be salmon, almost 3 grams per 100 grams serving. Though you have to be careful with whitefish from our Great Lakes. We did have a dad and his son come into Children's this year. They were living for the summer right around the Elk Rapids area, Torch Lake, and they were lower income, and they were trying just to eat all fish and from the lake. And the child had significant neuropathy and a tremor. We found he had mercury poisoning. They exceeded their limit of Great Lakes trout. They were eating basically trout and whitefish. And the child had significant mercury toxicity. He was 14. So there you go. Whoop. So we are looking at essential long-chain fatty acids. The alpha-linoleic acid is basically from plants. Our body can't make these, but the EPA and DHA are basically from the fish oil. And they're the best choices. They have more active anti-inflammatory compounds versus the ALA. And millions of rats and mice have demonstrated, they've given their lives in these paw tests, tail flick tests, to show that they promote beta-endorphin release with opioid analgesic effects. That's what these long-chain fatty acids do. That's why they're been useful in pain, chronic pain syndromes. That's why they counteract the central sensitization, which is thought to be the problem in these neuropathic inflammatory chronic pain conditions. This chronic inflammatory conditions such as CRPS, diabetic neuropathy, a whole host of our chronic pain conditions, they tend to respond to the omega-3 fatty acids. They may prevent the hyperalgesia that is due to the enhanced pain response, because they promote our own endogenous enkephalins and endorphins, our own endogenous opioids. Now, in sickle cell pain, this was done in Saudi Arabia, or in Sudan. This was children with sickle cell anemia and adults. And this is a problem always I have when you mix children and adults together in a trial, because they're not the same, they don't respond the same. However, it was a fairly well done trial where they were given omega-3 fatty acids in an age-appropriate dose. But they didn't control for other agents they were taking, but they weren't allowed other analgesics. And they were given omega-3 fatty acids or placebo. And they found after 12 months that the group that received omega-3 fatty acids had reduced frequency of vaso-occlusive crisis, and when they did have a vaso-occlusive crisis, like a sickle cell crisis, that they were reduced in severity. The group that got omega-3 fatty acids had decreased need for blood transfusions. Their anemia was better. They missed school and less. They had decreased hospitalizations. They had less stroke, well, which makes sense because the omega-3s have an antiplatelet type of effect. So that was really exciting. And you could see that the omega-3 line is the triangle line here, and if you look at events over a 12-month period compared to the placebo group, which is the squares, the omega-3 line had less cumulative events over 12 months. So that was pretty exciting. One of my students presented this for Journal Club, and it's a low risk, inexpensive type of treatment. And many of our sickle cell patients end up on methadone, Tylenol 3s, oxycodone, NSAIDS, and in and out of hospital. And if we could really try omega-3 fatty acids, it's a high yield, low cost, low side effect type of treatment. So we're talking to our HEMON group about this. Now, omega-3 fatty acids have been used instead of NSAIDs in low back pain. And we have shown in our own practice, omega-3 fatty acids have really helped patients with low back pain. They were able to cut down on their NSAID use. We have children taking Celebrex over time, and we have found that they are able to decrease from twice a day to once a day, and then eventually taper off over a 3-month period. So, and the doses vary from 1,200 to 2,400 daily, and there's a 60% improvement in this one group. This was 250 patients, which is really small overall. And 60% of them, though, discontinued. These were adults in this one trial in surgical neurology, NSAIDs overall. And almost the whole cohort, though, continued omega-3, and no significant side effects. So it's worth a try. And the trouble is with these agents, though, you have to have the patients stick with it. They have to continue it. It's not a quick type of fix. Though what we have found when the patients do discontinue it, they do notice a change in their pain after several weeks. It does definitely help. There's several case series out there with respect to high dose omega-3s. The median in this group was about 3 grams a day, where cervical radiculopathy, carpal tunnel, burn injuries, thoracic outlet syndrome, which is rare but very painful, that there's significant decreased pain and analgesic use and improved function. And cervical radiculopathy, which is the classic pinch nerve at C6, C8, very painful, very common, where they have the traveling the pain from trauma, improper lifting, repetitive motion. Many of our patients have that, very common. Chronic daily headache, a decreased impact score. This is just including it in diet as well, so it's just not the medication. Considerations, again, you want to think about effects on INR, discontinued prior to surgery, visible bleeding. Look for the EPA, higher EPA-DHA ratio. That's the essential fatty acid ratio. Start with almost 3 grams a day if you can, and look for high-quality brands to avoid contaminants. And there is an international fish oil sponsored program. It's from the fish oil manufacturers. There's a website, and it'll talk about a comparison of all the brands. And enterin-coated capsules will prevent your patients from burping. And the kids always say, oh, well, what if I burp? You know, I'll be unpopular. So, and you always want to tell them to take the food as well for better palatability. And I'm just going to do a quick time check here. How am I doing? Okay, great. Now I'll move on through here. I know Dr. O'Connell and Dr. Patton did a little bit on osteoporosis and vitamin D, so I'm not going to belabor this, but I will talk about the sunshine vitamin, since we have such a lack of it, and its effect on chronic pain. Now, everyone is vitamin D crazy in the clinics lately. I don't know if everyone has experienced the quest for vitamin D in their practice. Has everyone been besieged with requests for vitamin D. Now, what I found in my practice, if someone is vitamin D deficient or insufficient and they have chronic pain, it does make a difference. It really does. Now, there are studies and case reports, there are data. And if you replace vitamin D, you will begin to alleviate a chronic pain syndrome. There are data since 2009 in the literature. It will help migraines, chronic pelvic pain, fibromyalgia, Crohn's disease, and the most significant findings are low back pain. Now, the daily requirements here from the NIH in 2011, and I was showing this to my husband, Mike Blair, he said, well, why do you even have that slide? Because it looks as if you are, over 12 months, but under, 70, everyone gets 600 a day, the daily requirements, so why bother? I said, okay, Mike, I won't belabor it. So there you go. Thanks, Mike. So, vitamin D influences many functions, and what we do know, if you are deficient in vitamin D, you are more prone to the development of diabetic neuropathies. And in this side of the hemisphere, this part of the world, we are almost all deficient in vitamin D, we're finding. It's $56 at the DMC to run an ELISA test for 25 hydroxy vitamin D, and we are just adding it onto our labs. When in doubt, we test. And we're not so quick to replace, because if you over-replace or over-supplement, you can cause adverse effects as well. So let me tell you a little about vitamin D and low back pain. Patients with non-specific low back pain, we assessed, they assessed low back pain, and we're in the process of it. And then supplemented, 83% they found had low serum levels, and this is in Saudi Arabia though, but they gave all their patients vitamin D, 5,000 units to 10,000 internationally for 3 months. And at the end of 3 months, all had, normal. And they said that all patients who had initially low had their back pain went away. But even those who had previously normal levels, their back pain went away as well. So somehow, even those who had normal vitamin D levels found their pain was resolved. But in Saudi Arabia, many of the women wear hijab, and it's culturally unacceptable to expose yourself to the sun. Plus, it's very, very hot, and you would be hypothermic and dehydrated if you would expose yourself to the sun. So, anyway, here it's just impossible. So, anyway, now, how does vitamin D improve back pain? Maybe inflammation reduction, improve nerve function, improve muscle strength. We think it improves also depression and mood stabilization. Vitamin D and chronic pain, we say screen all your patients, and if they are deficient or, deficient, replete, and we think the maximum effect is usually there in about a month, though there's some controversy out there. It takes about 3 months to get to steady state, though we would check probably in about a month to 3 months before we would make a change. A desirable level is about greater than 32 nanograms per mil. We don't know with children, but we're just going with the adult range. High doses, we have seen vitamin D toxicity. We had a child that took the 50,000 replacement. He took 4 months of a supply in a week. He was an 11-year-old taking his own meds unsupervised, and he had a headache, he had nausea, vomiting. So it's possible to over-replete. You have to watch. Now, obese patients, we have a lot of obese patients, surprise. And it seems that they have trouble absorbing vitamin D from their skin. Inflammatory bowel conditions tend to have, we have a lot of Crohn's patients, inflammatory bowel conditions, so that is a risk factor as well. If you have and patients on anticonvulsants, so those are risk factors. And there are some replacement schedules. I refer people to Lexicon, drug handle as well. Drug interactions, I won't belabor those. Now magnesium, that is an interesting drug. A lot of data on how it improves pain. It has many actions in the body, muscle contraction, relaxation, nerve conduction effects, and that is probably where it relieves pain through nerve conduction. IV and oral formulations, but the salt, as you know, the salt form varies in magnesium content. As pharmacists, we know that. The physicians may not, but we're the ones who will straighten them out. Its analgesic effects were first discovered in a trial in 1996, but surprisingly, it has no effects in fibromyalgia or in muscle cramps. Now we know that if you're deficient in magnesium intake, you're at higher risk of death and stroke, diabetes, and migraine headaches. There's level B evidence that means it's possible, and that's in the neurology guidelines that magnesium loading in the event of an acute migraine is recommended. That is possibly effective. The highest form is A, and then this is B. So it's an NMDA antagonist. Others are like methadone, ketamine. So it opposes calcium influx. It decreases opioid tolerance as well. And it relaxes skeletal muscle, increases tissue perfusions, oxygenation. So if the tissues are being perfused, you feel better. And it also works on serotonin receptors, increases nitric oxide release, and again, that action on the NMDA receptors is very important. Now, this is the dorsal horn neuron. That is the presynaptic and the postsynaptic neuron. Substance P is being released there. That's activated, and glutamate, which is an amine that causes, it can cause pain. The activated NMDA receptor is right there, and endogenous magnesium can go and block that activated NMDA receptor. You see the opioid receptors there, but that shows the important role of magnesium. And if we give exogenous magnesium, it can boost activity right there at the NMDA receptor, causing pain relief. Because sometimes, like post-op, your magnesium can be low, and that can also, and during migraines, too, magnesium is low. So magnesium prior to lumbar surgery has helped. That's been shown in randomized controlled trials. We see patients using less PCA and less opioid post-op, better tolerance with anesthesia. This is another trial showing that improved sleep, better pain score post-op. Chronic spine pain, magnesium 1 gram infusion, followed by oral. Lumbar spine with neuropathy, improved pain scores, better flexibility, better range of motion. Pediatric migraine. Patients with pediatric migraine, it has about 11% of children under the age of 11 years old have pediatric migraine. And then that's about 25% over the age of 11. So this is a big time problem. So magnesium, we've used this in our clinic, and this is very helpful, and also it increases time of onset of action of their acetaminophen and their ibuprofen. Data is rather limited though, but it's also been used in post-traumatic headache, which children are at high risk for trauma. So post-traumatic headache after car injury or bike accident, those are very persistent issues. Sickle cell crisis decreases pain and length of stay. Magnesium, you have to watch diarrhea. Those patients receiving opioid, there's opioid-induced constipation, so this counteracts it. Monitoring parameters, again, monitor in a patient who has creatinine clearance less than 25 because you have a problem with accumulating in renal function. I'm going to move along to coenzyme Q10. Anti-inflammatory and antioxidant, improve conduction velocity, decrease neuropathy symptoms. Now there is definite evidence that this may slow the progression of diabetic neuropathy due to hyperglycemia-induced superoxide cell injury. This is very exciting. This may actually slow the development of the superoxide cell injury, and although the duration of effects may be unknown, you may have to stop the drug and it just may revert. And this has been shown in a recent anesthesia paper. It's also been used in osteoarthritis, statin-induced myopathy, migraine. The dosage ranges vary from 30 to 200 daily. Adverse effects are rather rare or mild: nausea, vomiting, decreased appetite, diarrhea. Sometimes, depending on the preparation, there may be soy, and some patients do have soy allergy, and I've seen rare, almost anaphylaxis types of allergies with children. Now, and interactions. Warfarin, anticoagulants, and sometimes you'll get a hypotensive effects with antihypertensives. Now there's a case from practice I want to go over really quickly. There is a 52-year-old woman with a past medical history, chronic left hip pain, depression, chronic back pain, and she's scheduled for a left total hip replacement. And she smokes half a pack a day for 20 years. And she's using diazepam every 8 hours for muscle spasm, tramadol every 6 hours as needed. But she's taking it basically around the clock. And gabapentin 900, 3 times a day, duloxetine 30 milligrams daily, and 5 out of 10 on the 0 to 10 scale. That's as best as she gets. She comes, she sees you as the pharmacist, pre-op. So what are you going to do for her? What do you think? Well, this is what I'm going to do. So I'll tell you. We know she's opioid. Benzodiazepine dependent, right? If anyone wants to jump in and say anything different, I like to argue. My husband knows that. She may benefit from an antioxidant supplement, yes. She's at risk for vitamin C and vitamin D deficiency. She's this low back pain, depression. She's also a little bit overweight. But her smoking may decrease her pain, right? Because smoking, nicotine's a vasoconstrictor. We have some pre-op considerations. Let's get a serum 25 OHD level. We're at the DMC and we're going to just order one up because we have a collaborative practice agreement. We're going to give us a pre-op magnesium sulfate 2-gram IV infusion. And we're going to hope that decreases her pre-op opioid use. And if you want this slide, I can give you my email. I can give it to you. Everyone agree? Okay. Comments? Well, we have her labs. That's a good point. You know, her creatinine is normal. We have her labs. So that's a point well taken. She's in the normal range. But that's a point well taken. We have her labs, but that's a good point. So, post-op, she's going to get PCA. We're going to start some vitamin C, 1,000 milligram daily oral. We're going to evaluate and supplement her vitamin D. Magnesium oxide, 400 milligrams oral tablets twice a day. You know, post-op. This is when she's tolerating orals. You know, we're going to convert her over. Taper her diazepam because we're going to hope that magnesium will act as her muscle relaxant. DC or tramadol. We're going to give her some smoking cessation. Hydrocodone 325 every 4 to 6 hours is needed for acute post-op pain after she's tapering off the PCA. And then we're going to limit her quantity and her refills after her PCA. Hopefully, we're not going to refill anything, you know, after her initial discharge script. And we'll work with her outpatient pharmacist. And then we'll continue the gabapentin, and we'll continue the duloxetine, 30 milligrams every morning, monitor her mood. Consider working, we'll work with her psychiatrist or her prescriber. We'll find out who's prescribing this to her because she's been on it for a year. And I find these patients just sitting there on that SNRI or the antidepressant. Don't you find that? And they're still depressed. They've been on it for forever. It's like, no one's monitoring her. And bowel prophylaxis for opioid if needed if the magnesium doesn't do the trick. What do you think? Comments, suggestions? So.
The vitamin C seems to, it comes out pretty quickly. Would BID, would a 500 be a little better choice?
Well, we could, you know. We could do twice a day as well. You know, we could. So we could do that. Now, this is, you know, typical. We could do twice a day. You know, I just started once a day. And it seems like we're doing a lot at once. I'm sorry. The question was, should we consider the vitamin C 1,000 twice a day instead of once a day? We could, you know, the data, you know, that would be in the range. You know, we could go, you know, 1 gram, 2 grams, you know. I just, you know, she could do that if she wants. We could encourage her, you know, to do that.
Do you wait a day or two after surgery just to help reduce chances of nausea?
Well, this would be when she's tolerating her orals, you know. We would see, you know, that's a pretty big pill load, but when she's starting her orals, we would start adding this. But it's true, we wouldn't add all this until she's definitely on the road to eating all of her meals, basically. But we would try to get all this in, because the sooner she starts this, the data shows it's better response. So, any other comments? Or? Do you want to do the self-assessment? Yeah. Okay, we'll do that.